We are live. Hello, everybody. Happy Friday. Thank y'all for being here with us on Airway Circle Facebook Live. We have the incredible Michelle Emmanuel today. Thank you, Michelle, for being here.
You're very welcome. I'm glad to be here.
Great. Guys, if you don't know, Michelle has been a pediatric occupational therapist for 25 years, specializing in posture, movement, social nervous system, and neurodevelopmental optimization of the pre-crawling infant. She uses a variety of manual therapy and holistic nervous system-based treatment and is a developer of several professional curriculums, including TummyTime method and Therapeutics, baby reflexology, and BabyMyo. Our topic today is how do airway issues impact baby's nervous system regulation? And also we have Ruth with us. You guys know Ruth. She is our Airway Circle OT. Hello, Ruth. If you guys can hear us, if you guys are watching us live, please type hashtag baby on the comments. So we know you guys are listening. You guys are there. Please post your questions in the comments. Michelle will be happy to answer them as we go along. I cannot wait for this talk. We are ready to learn from Michelle. So the floor is yours.
Wonderful. I'm so glad to be here, and thank you for having me. Also, thank you for wanting to talk about breathing and how that affects babies. Because in the myofunctional therapy world, we know breathing has a big emphasis, and it's easier to think about doing breathing assessment and training and treatment with bigger people, but what does that look like for babies, and what impact and effect does breathing have on the nervous system, and what impact does the nervous system then have on oral function? So basically, one of the things we know about babies is that the coordination of breathing with sucking and swallowing is paramount as it relates to good feeding and autonomic regulation. So when we talk about coordinating breathing with sucking and swallowing, that means that the breath is actually regulated by sucking and swallowing. And when there is tongue dysfunction or feeding problems or oral restrictions, this impacts the nervous system. And it's a bidirectional relationship. So the nervous system affects function, and the function affects the nervous system. And the primary requirement for the ability to coordinate breathing with sucking and swallowing is good cranial nerve integration and good cranial nerve function. And we know that since the cranial nerves innervate the muscles of the face, the jaw, the tongue, the neck, the shoulders, a lot of our trunk muscles too, even with the accessory nerve, and the overwhelming influence of the vagus nerve, which has a lot to do with autonomic regulation and breathing itself, as well as the coordination of breathing with sucking and swallowing. This can be quite a barrier, an obstacle for a baby feeding, connecting, even their digestive and airway patency themselves. I'm looking forward to hearing what kind of questions you guys have. If you do have any, we can continue talking as we go along too.
I just wanted to make a comment. It's so important that what you're saying, that we need somebody to be looking out for these babies, because we as adults, we recognize whenever we have an issue. We can tell whenever we're not feeling good and we're having difficulty with certain things. And there's plenty of professionals out there to help adults whenever we're not breathing well, because it affects our whole life. You can't breathe well, you're not going to sleep well, you're not going to feel good. And how about these babies? What are some signs that we should be looking for that these babies might be telling us, we don't feel good, we can't breathe well?
Babies communicate differently than adults today.
Exactly. I think the number one is the breathing rate. And if that is higher than what we want it to be, which is usually 30 to 60 breaths per minute, that's going to automatically be a clue. The other thing is if you don't see the belly moving up and down, and if the belly's not moving out on the inhale and in on the exhale and out on the inhale and in on the exhale, if that movement is not happening through the belly, we know we're not getting as much respiratory diaphragm engagement, and we're also not going to be stimulating our digestive system very well at all. That also puts a baby more in that fight or flight state. So it's the baby that's fussy, that can't settle, that's squirming and worming all over the place, that grunts, and it just doesn't give us that calm sense when we look at them. So those are really, really obvious ones, but missed by a lot of people, including many pediatricians.
I'm relating.
The problem
to this.
is because, go ahead.
I'm relating to this as a mother. So my first one had colic. You know, we hear so many mothers talk about, oh, my baby has colic or purple witching hour. But we talk about this as something normal. Is it normal or is it common? And what do you think about this colic that we all talk about?
Well, that's a great question because it begs the question, what is colic? And when we realize that colic is just crying a lot, and I don't mean by just, but colic is crying, and it's a dysregulated state triggered and stimulated by some other physiologic event. In the absence of some other insult that we know about, it's usually coming from the GI system. And these interoceptive signals from the gut overwhelm the vagus nerve and the ability to regulate all of the input. And this can be for many different reasons. But colic is a reason to look further and dig deeper, not just name it and move on. So colic can also be, it can be the airway patency issues as well, because if we have breathing dysfunction, that causes at least reflux to increase. And so there's an inverse relationship between airway and digestion. And so colic is what we say, because the main reason is because they don't have a lot of answers to what helps colic. And that, I mean by they, it's the pediatricians. And so they know that neurodevelopmental maturation and hopefully growth and development change that. But colic is a reason to dig deeper and to ask more questions and to implement some sort of therapeutic modalities that can help the autonomic regulation, the breathing dysfunction, and also the belly problems, whatever they are.
Michelle, do babies learn when they are in a state of dysregulation like that? Or I'm heading towards your polyvagal hierarchy idea of where we have to be, and kind of explaining more towards how we have to be somewhere in the middle. So will you elaborate more and share?
Yeah, so that's a good point, because a baby that's in that colic state or is fighting or flighting or is in this dysregulated state, there's not a lot of learning that happens. And what it is the baby goes into protective mode and will put up defense systems in order, and so will actually fight. And that often makes other maladaptive things deeper. And that's a little bit of the problem, because we do want to put on our priority, the number one thing is to help the baby regulate. So whatever that looks like, I mean, we got to figure that out. That's the detective work. That's the assessment. That's the specificity that we can apply to each baby as they present with their unique symptoms. But what we do all hold in common is that we're in defensive mode. We're not going to learn. And if we're being traumatized at that time, we'll learn, and we'll learn really quickly to avoid all of the stimulus that reminds us like that, or that is like that. And that's where oral aversions can develop, and they can be very subtle, and it can be something that it just interferes with the sensory processing in the mouth. So yeah, we don't want to do, I mean, obviously we're working with babies and they cry. There's a big difference though between a baby crying for communication or even stress relief and a baby crying out of dysregulation. And we also need to be very careful about how much we do with the baby so that we don't get them out of that zone where they can learn. In the learning world, we call that the zone of proximal development. And that's the sweet spot where the baby's getting challenged the right amount for what they need to do. And if they're in the fight or flight state, they're way, way, way past that. We can't really learn in that state effectively other than to protect ourselves and or remember that we don't want anything else to do with that stimulus again.
What is the difference between co-regulation and self-regulation?
Well, self-regulation, let me start there, is an acquired skill based on co-regulation and a history of co-regulatory experiences and our nervous systems gaining the robust ability to manage and handle challenges in a way that's pleasing enough to have an interaction on whatever level is required. So it's about the just right challenge, you know, always. So ask me the question again. Let's get deeper into it.
All right. What is the difference between co-regulation and self-regulation? Me as a myofunctional therapist, I really know nothing about this. Ruth was trying to teach me.
I was like, just ask Michelle.
Well, it's such a great question because when we talk about it a little bit and then we ask the question again, we realize that we understand that co-regulation and self-regulation perhaps are two different things. And that's neat because self-regulation is sort of a hierarchical leap from co-regulation. And even now, I mean, our nervous systems, because we're mammals, are built around having social, emotional, and interactional experiences as a way to calm our system down. So when we share eye gaze and facial expressions and vocal prosody and all of this back and forth, we actually go into a parasympathetic response. And that's where we feel good, our heart rate is low, our respiratory rate is low, we're willing to take a chance to do something new, and we're open to the possibility. So that's one thing about how we actually are all designed. So even us as big people, and we do think of self-regulation as a skill we get a little bit better with development and maturation, and it's true, we do. We need a lot of co-regulatory experience early on in the 4th trimester and even in the entire pre-crawling period. We need a lot of holding. We need a lot of social engagement. We need a lot of experiences where we go through the challenges together and we're heard and acknowledged. And then with a little bit of those experiences, making babies and helping babies feel supported, they can then take a chance to do something new and maybe play with a toy for a little bit and then social reference back with a parent and this co-regulatory eye gaze. And then the threat of it decreases because the parent's saying, yes, that's very good. I really like that. And there's this mutual joy that's had. So self-regulation starts in very small doses. And we can see young infants have self-regulatory experiences, such as grasping onto their burp cloth or putting their foot against their other leg, which is called foot bracing, or holding on to their clothes or bringing their hands to the middle or bringing their hands to their mouth. These are all emerging self-regulatory experiences, but they need to be then caught up in the co-regulation, meaning eye gaze, facial expression, vocal prosody, closeness, and warmth in order to cement those in. So even as older people, though, and adults, let's say we do something that's challenging for us, and then we go out to lunch with our girlfriend and do all of those same things using eye gaze and facial expressions and vocal prosody to help process the situation, to understand the situation, and to grow from that. I think that's one thing as humans, we're constantly on this always evolving path of getting better. And having more self-regulation is a very good skill, but it doesn't matter. We continue to co-regulate throughout our life, but we really need it hardcore in the first at least 1,000 days of life.
Wow.
But yeah, self-regulation isn't the goal. Like, self-regulation for a period of time is the goal. And then pulling back into the safety and the beauty and the joy and it's really safety. It comes down to it. But joy is really a good bonus of the co-regulation. And we want to teach people and each other to rely on that, because that's our humanness. And that's how we then, if we want to face our breathing dysfunction for all of us, we get into those co-regulatory experiences. That's when we can actually breathe the lowest and the slowest.
I was about to
ask. We can get really slow. Go ahead.
I was going to ask you, how do we bring that back to breathing? And airway, because we know if we're having a better experience socially, we're a lot calmer and better regulated, I guess. And so that's kind of when our breathing also is associated to getting those deeper breaths and not hyperventilating or holding our breath. Some people don't do the opposite. And so how does a baby work on that airway, though, is kind of bringing it back around. But it was just the direction you were going.
Yeah, that's exactly how. So rather than like coming at it as necessarily a breathing exercise, it's more of a co-regulatory experience. And we can entrain with each other. So we will go over using polyvagal theory. We'll exhale for longer than we inhale, and automatically we'll get a down-regulated response. And interestingly enough, go ahead.
It's okay. Go ahead. You can finish your thought.
I was going to say, interestingly enough, the things that we do when we exhale as a parent are singing lullabies, talking parentese, using this lilting voice that is, robust with safety and I'm here and I want to be here for you. So the lengthy exhale will then have this interpersonal synchronization, and the baby begins to vibe on the parent's breathing, and that can be a great exercise. And that's actually true for all of us. And I've always said that anytime I'm ever teaching, it's all up to the strongest breather in the room. They're going to set the pace and the tone and the atmosphere. And breath can be something that is so powerful for not only helping us feel like we shift out of fight or flight into either a more regulated movement part of the state, or into social engagement, or into a parasympathetic, just a still place where we don't have fear. And that's a very powerful thing, because when our nervous system feels safety, that's when we're able to learn. That's when we're able to get our tongue up. That's when we're able to let go of the tension in the jaw. That's when we're able to elongate the neck. That's when we're able to relax the pelvic floor. That's when we're able to really move the diaphragm and stimulate the solar plexus area, that's really important nutrients, and the lymph system in our bowel, etc.
Wow.
But there are also like other.
As adults, we know breath work and we know what we're supposed to do or teach our older patients. But with a baby, how do you teach them this breathing? And you just mentioned singing lullabies, and by the parent regulating their breathing, it can affect the baby.
I do it with my older kids too. I'll hum and kind of, and nice swaying vestibular motions, very rhythmical. I'll use that a lot, not just with my babies, but my big kids too. It's all regulating, and we're looking at all of those different sensory inputs, right? And sometimes we forget that babies are just little humans.
We forget that a lot. And we also, you know, one of my little pet peeves is that we always want the baby to be something other than they are. They want, you know, it's like a future firefighter or like a future myofunctional therapist or something. But, you know, an 8-week-old baby has the right to be an 8-week-old baby.
Yep.
And what it means to be an 8-week-old baby is what we need to help people really, truly, fully understand, because they have these very rich, expansive lives that we don't really understand or tune into. And when we do, we realize that, you know, this breathing thing is behind almost everything. And like Ruth was mentioning, with anybody at any time, the number one way that you can notice someone and their emotional shift even is through their breathing. And you don't have to even have an audio on if you're watching how the breathing and where the breathing is. If you're seeing the breathing up here in the neck and the shoulders, that's automatically in a sort of fight or flight state. But if the belly is moving and it's going in and out of the body easily, that automatically tells us. I track the breath the entire time I'm treating anybody.
Wow. It's incredible how
and it's
the way that we act and the way that our state, I guess I would say, affect others around us. I would have never thought of that.
OTs are specialized in therapeutic use of self. I think it's why OTs are really extra special in this space. I'm really biased, though.
Well, Ruth, we've spent a lot of time making this a specialty, and there aren't any other professions necessarily that have focused on putting this together. So it is a little bit of a unique angle. And the therapy is, we're using that all the time. And we can understand when someone comes in through even the front door, I'm already working on, you know, the breathing. Are you guys there? Because you cut out just a little bit.
Yes, I can hear you.
So when the parent and the baby come through the door in my office, that's what I'm checking for. And I'm also making sure I'm in a state where it doesn't mean you can't have something on your mind, because we're humans and we have lives too. But if we keep our physiologic parameters where we're non-threatening and we're exuding cues of safety, and we tune in and help to lower, right? We exhale lengthy, and the person entrains to us. And a lot of times you'll hear a sigh, because that's often a reset sign. And then we can actually think clearly. Until then, things are swirling around really too much. And a lot of things come to our awareness because we're all extremely intuitive if we pay attention and we slow down and we want to be able to see things and have an expanded awareness. And this is where emotions, and there's tears that happen in a session, and there are realizations that happen, and there are releases of blockages emotionally that happen, because we're talking about babies right now, and there's nothing we worry about more than our kids. Okay. So for people that don't have kids, you worry about things, but with people with kids, there's nothing you worry about more than your kids. And this is a very delicate time as well, which is another reason why there hasn't been a lot of specialization working with babies, because it's a lot of responsibility to point out things that need attention, and that can be, confusing what to do. There's a lot of different opinions, and everybody has access to so much information that it's just like swirling and swirling and swirling. We get into the office and we begin breathing, and not like It's not hokey. It doesn't feel weird. You just slow down the breathing rate and the thoughts become clearer. And that happens for the families as well. But I agree, OTs bring a really special, unique thing. The other thing is we really like to work collaboratively. We like to hear others' opinions, and we take that in and we try to help. OTs are always trying to make, how can we make that PT session easier for the baby or the child? And we're always collaborating and with different things. So I think that's a really unique part of it as well.
You made me think of, I'm just going to share a story, but I remember getting points taken off in a test in grad school because my voice was too perky and I needed to have a calmer, less perky voice. And I will always remember getting points off on my practical because my voice was too perky for the high tone baby. And I was like,
I would have failed it.
So I know, like that always makes me like recheck, like what if something's not going right? How can I reset myself? And if I reset myself and slow down my breathing, bring my voice down, and put on my spa self is what I call it. I'm going to the spa, and how can myself help my patient? And so, what can we do in order to help these babies have better function, really, is why we're there, right? I see a lot of babies and children that already have a lot of problems. But what about you, Michelle? Are they coming to see you with a lot of dysfunction already, or are you seeing them before they have a lot of dysfunction?
I think that depends what you call a lot of dysfunction, because no one taught me what I'm doing except the babies and my own curiosity. I've had a lot of teachers, but some of the things about the nuances of a baby and the level and complexity of dysfunction has come from astute observation in these parasympathetic, ventral vagus, highly evolved mammalian circuits, as well as an immobilized platform. I spent 9 years working in a NICU, and I was telling one of my moms the other day, I said that it was really interesting to think about kind of how it's changed and evolved, because I worked in a very high level NICU where babies were there for extended periods of time. And so there weren't always parents at the bedside as you would see in a traditional NICU where it's a birth hospital, because I worked at a children's hospital and they're all referrals and surgical and long-term and like really chronic high acuity cases. And so a lot of times and the nurse we developed, rapport and trust over the years. I would come to the bedside, that would give them a tiny break from that baby, and they would go do care. A lot of times they would have 2 and sometimes 3 babies, depending upon the level of acuity. And it was just the baby and I. And there's something extremely reverent, I think, that happened there. And there was a lot of babies who were on vents. And I found myself, from days like I would be with a baby and I was, and I'd realize I was breathing with the vent because I had tuned in and entrained. And that's where I learned the strongest breather in the room, and like how to like work with a baby and help to work breathing patterns, but not take on the vent patterns, and how to, modulate that. And so when I apply that, and I said all that to just say I've worked with really, really sick babies, but so that was very complex. And now my caseload is primarily typically developing babies who don't have a diagnosis of anything, may or may not have a tongue-tie diagnosis or a lip-tie diagnosis, may have colic or reflux or torticollis or plagiocephaly. So some of these things, but not really anything other than that. And I'm seeing just as many complexities and nuances and dysfunction. It's just as the babies grow, the symptoms show. But if you have the eyes to see and the ears to hear, the dysfunction is very loud, early on. And so it's more about learning the nuances. So for me, everything is complex. Okay. I can't help it. That's one of my, things. But also I understand and I respect at a very deep level that babies are humans too. And we can't project adult psychology onto them. They have a completely unique journey. They're not little people. They're not little children. They're not little toddlers. They're very unique, this pre-crawling baby. And we can have powerful therapeutic effects, but you can't affect the baby without affecting the parent, and you can't affect the parent without affecting the baby and the whole family as a unit as well.
What are some things that society has pushed on parents right now? There's not a responsibility, but almost a, things that society has pushed that as parents, we have to do these with our children that are completely ignoring the baby as a human being and might be affecting the sensory and regulation. Everything.
Can you ask me if there's something we're not doing? Okay.
Why are people not paying attention? This is so important.
This is so important, and thank you for giving this a little bit of a stage. I have a lot of opinions about this, and if people want to connect with this, let's make another, attempt to get at this. But one is that babies, people really fear babies. They don't understand what they're supposed to do. They don't understand what they're looking at. They aren't really sure how to negotiate the relationship as well. And if it's going well, that's easy. I'm talking about babies who struggle and have problems. And I think that it's like anything else. This is a very precious time when someone has a newborn, and we think our cultural expectation is that babies are perfect and everything they do and think and want is perfect. And that's just, it is true. They are perfect in the way they are, but that doesn't mean they don't need assistance. That doesn't mean they don't need help. And actually, nature tells us this through giving us the concepts of the 4th trimester. Now, we put a label on this, but it's really this 12 weeks after birth where baby is still gestating. But because of our pelvis and the size and shape and our head and our brain and our prefrontal cortex and our jaw and our airways, we can't continue to develop in utero because the physiological flexion and the shape of the baby in the womb lends itself to a lot of flexion as the baby gets bigger and bigger. And it's time to balance flexion with extension. And the baby has been using extension this entire time, straightening its body and going back into flexion. But it's time to really work with the bigger balance of flexion and extension. And as we're born, the first move we really do is this big guppy out of the vagina, okay, where we get the extension in the neck and head, and then we come into the earthbound plane. We begin to experience gravity for the first time. And these experiences, along with the physiological transition and first breath, coupled with the breast crawl and the natural first latch, actually imprint on the autonomic nervous system a lot of information about safety, the environment, swallowing, airway patency, gravity, and those forces, because all of a sudden there's this primitive reflex that's being stimulated by the gravitational field, by the Higgs boson. And the baby, and it's going to be dependent on position and space. And going back to what the cultural barriers are, is that not understanding that babies have this really super rich life. And even if you've watched that movie Babies, have you seen that on Netflix?
I have.
I watched that and I'm like, yeah, I'm watching that going, this leaves a lot to be said. Okay. So it's really good that they do it, but it leaves a lot to be said and a lot to be understood about the lives of babies and what they really need. Because the other thing is, besides not giving them a full breast crawl or a natural first latch, or to even equip and make sure that the gestating parent understands what that is and what to expect and how to support it, that's a major cultural barrier. And the other one is obviously back to sleep and the lack of ventral surface weight bearing. And so I'm not against back to sleep. I'm just saying that puts our babies at a certain disadvantage, especially from an airway perspective, laying in supine. That's a very difficult position to maintain if you have airway patency, tongue tone position and strength, oral rest posture position, and also if you have reflux or any kind of digestion. So there's a lot of compensation that parents have to go through to be able to get the babies to do that. And what that requires is inhibiting movement. And one of the things about babies that we know, other than being very sophisticated from a social, emotional, interactional perspective, is that they need a movement prolific environment. And we just aren't set up a lot of times to support parents with that or to emphasize that. And it goes down to obviously containers and containment and, infant furniture use, but it's also just how we handle the babies. And, sometimes I'll meet a parent and the baby's already 5 or 6 weeks old and they just kept putting the baby to the one side because that's what he liked. These are just really nice people. They don't understand that it's really important. And this is the other thing, like we've changed all these biological things because prior to back to sleep, babies were spending half their lives on their tummies. But what we didn't tell parents, and where I think, the problem is we need to equip and have more education is, hey, we're in a back to sleep culture. That means you are responsible for turning your baby's head and your head position, but we miss that step. And so a lot of babies have more exacerbation of their symptoms because of this. So I think that's a big barrier. And I also think that because there's so much growth and development and maturation that happens in this pre-crawling period, that many pediatricians, because they're extremely busy and highly valuable, but they're overloaded, they'll take more of a wait and see approach. And they'll want to treat something when it gets bad enough to treat it rather than getting on the front end of it and working on an optimization or a prevention model. Some do, but most don't.
That's where
it's a reticent, really. I don't know. Yeah, but I really don't understand why pediatricians aren't more willing to refer, because a therapist is not going to justify doing therapy or anything if there isn't a need for it. So they could send for evaluation and pass that information back and forth and perhaps be able to expand our repertoire. I think the other barrier is that we don't have much research on this population, because who's going to research typically developing babies with mild issues that are not even really being addressed by their pediatrician? It's really, there's a lot of barriers professionally and personally.
Wow. Drop the mic.
Michelle, so we're talking a lot about movement too. So what is the importance of getting these babies moving earlier in regards to their airway, moving this way, and how that affects opening up that airway and getting that good and setting them up for success later on in life?
Yeah, well, we're, from that time of birth and coming earthside, that's our first real job, is to set up our airway patency, especially our upper airway patency. And that's dictated by our tongue tone position, strength, and function. So when the tongue is not doing what it's supposed to do, there's an effect on the whole body. And it can inhibit reflexes. It can make reflexes be exaggerated, because the tongue being the epicenter of development, it's going to have an impact on all the other things on the body. So one thing I think, we really need to focus on is doing more, obviously, therapeutic tummy time. And everyone knows that I love that position. And it's not just the position. I created the tummy time method. It's not just about being on your tummy. It's this whole sequence of things that's designed actually to get the autonomic nervous system regulated, because when you can do that, babies are comfortable in all of the positions. But when you take a baby, a pre-crawling baby, and you put them in the gravity field, if you lay them on their back, a baby on their back, there's only certain amounts of movements that are really provoked in that position. But when you put a baby on their belly and they are in the tummy position, the ventral surface weight bearing, the nervous system is activated, elicited, and interested in doing a whole plethora of movements. And they're cephalocaudal developers, meaning from the head to the toe. So this area is going to be the most sophisticated mover. And the tongue should be the best thing the baby's got. So when we know that the tongue is in fact not the best movement that the baby has, you're going to start seeing symptoms outside of this midline organ. Okay, so we're going to have the baby in tummy time regularly. We're going to have to work on other positions and also how we handle the baby in order to provoke the right sensory input. You were mentioning earlier, Ruth, the vestibular input. And we all know that babies love to be kind of swayed and rocked. And that's because you're stimulating.
It's a whole sensory experience. They like that proprioception too. Babies love to be held, right? Because think about when a baby's held, you're using all of this to hold them. They're getting all of that surface area. So more sensory input, but that calming sensory input, not that high, peppy voice that I got those points off for.
Yeah. I mean, I can see how someone would give someone feedback about how to use their vocal prosody to dictate the pace and the rhythm and the timing, but too perky doesn't give you enough feedback to know, because it doesn't give you enough. What'd you say?
I still remember it to this day, so it did make me a better therapist.
Oh, the best things. I still hear little things in my own head that, woo, yeah. And it's really good because we're willing to learn and change ourselves in order to meet the person where they are at a deeper level. It's really important. It doesn't make us a perfect person, and it doesn't mean that I don't still have problems in social interaction. It just means that when I'm in my therapeutic presence is the real thing. And it makes a difference. And it does for you too. And, it feels like love.
Right. And we love our patients at the end of the day, and we want the best for them. And so helping them and teaching them, but we're part of their journey. And I think that that's what makes working with these babies so special, because we really are part of the family at some point, because their moms are there with them, or their dads, the whole family. I have brothers and sisters in sessions. And so we are blessed, I think, as OTs, that it's the whole family. Like we're part of this whole group. The baby's part of that unit. And so helping the baby really helps the whole family.
Yeah, I want to say one thing about COVID, though, and thank you, COVID, is that I stopped having siblings come to therapy sessions because of COVID. We just didn't have any additional visitors. And I have come to realize that the therapy is better when siblings are not around. Okay. So the parents are able to pay attention and to focus. So that's something that I'm going to keep. And I love that too, having the siblings from time to time. But it has been such a radical difference in focus and concentration, because when we're working with babies that need a frenectomy, there's a lot of information and there's a lot of things to do. And it gets the anxiety level up. And so it helps us manage that even more, because the siblings would feel the parents' anxiety and then they would do something to kind of like get their attention and pull away. So anyway, I also want to consider what we can learn through adversities like COVID in 2020 to make our small time with the parents and the family more poignant, better seed planters.
Mm-hmm. I've been writing some questions down, and Kelsey had a question earlier. She said, what is the likelihood that preemies have airway dysfunction and thoughts?
It's a very high correlation. I don't know that there's any studies really, but I think that's, I think oral dysfunction and or restrictions, which are embryologic malformations affecting the fetus throughout gestation. It affects the pre-birth. It affects birth. I mean, that's even for me, if you have birth trauma, we're not necessarily treating just the birth trauma. The birth trauma happened because the baby wasn't equipped and or the situation, some kind of mismatch happened in the natural, normal birthing biological imperatives to stop that or slow that down. A lot of babies get stuck or they've been in one position for a while. And so even these things like that are signs and symptoms that there's a movement problem. You know, babies don't develop torticollis, and you can't prevent torticollis because torticollis isn't anything more than tongue dysfunction and lack of movement. It's a persistent asymmetry, and it's like really drilled in patterns. But all of these things are signs and symptoms all along. And so we need people working on the ground everywhere. We need people working with pre-crawling babies like I do. We need people working with older people. We need people working with pregnant people. We need pre-pregnant people. We need to start even early on in adolescence, teaching people how to take care of their bodies and their sex organs and their womb and their seed and their egg and all of this. It's really important. We realize the depth of this as we pull in this truly collaborative thing, which I love. The Airway Circle, Renata, you guys have done something so amazing to pull in people from all these disciplines, and not just therapy, but dentists and nutrition and like all of these things. We need to look at it from a mental health angle as well. And so I really appreciate all that and being a small part of the success of your program. And I've learned so much just listening to your guests, and I've enjoyed so much. You put so much time and energy, and this is your baby. This is talking about babies. Airway Circle is your baby.
Definitely. Well, thank you so much for being on our advisory board. We are blessed to have you here. My goodness, you are one of a kind, Mrs. Michelle Emanuel. You saw the first time she came on Clubhouse, I'm like, oh my gosh, Michelle Emanuel's here.
We were texting back and forth, and I was like, oh my goodness.
We have a great question from Kim. Kim said, hi, Michelle. What do you suggest for newborn or young babies with open mouth posture? I have often heard babies are born obligate nasal breathers. However, I seem to be observing mouth breathing more and more in newborns. Who would be the best provider to refer for this?
That's a great question, because one, the baby may have open mouth posture, but they're not mouth breathing yet. All open mouth will lead eventually to mouth breathing. So we want to intervene. But there's very few babies, if any, that are actually breathing through their mouth. And so they are still breathing through their nose, but the jaw is open, but the tongue is usually really bunched and humpy and actually occluding the airway completely. And the tongue is even sometimes up. But I would say over the period of 5 or 6 months, mouth breathing can and will develop. So just because it's open, there may not be mouth breathing, but we want to optimize oral rest posture regardless if it's open. So we want to do very simple things. There's a very easy thing that a parent can do, which is go up into the doughy part under the tongue and press upwards a little bit to close the mouth. You can work on positioning, so that like if their head is back or it's turned and twisted, sometimes that makes the jaw come a little bit more open. Facial massage can be a really great way because that engages the muscles of the face. And we want to remember, though, that the nervous system is giving the information for the muscle tone and strength and posture. And it's going to get itself into the position where the airway is the most patent, even if that's maladaptive, even if that looks like this or it looks like that. So it's all information that we need to utilize in order to give the proper treatment. But there's no way we're going to get better at this if we don't get enough therapeutic tummy time, which is another thing you can add that really does, even though it's a whole body treatment, focus in on the mouth. Okay, so we can close the mouth, we can do facial massage, we can do therapeutic whole body tummy time. We can also use positioning and alignment. So if the baby's like laying on the mom like this, You know, we can use gentle positioning and get the baby where they are in a position of support. They're opening their mouth in an attempt to make the airway bigger. That is always going to be, even if it looks really maladaptive, it's an attempt to help the baby breathe better. So we need to problem solve based on that information.
Michelle, how young can you start therapeutic tummy time? When can you start working on the tummy? I think some people are a little surprised by what you're going to say.
Yeah, right away, right at birth. And actually, the American Academy of Pediatrics has it in their tummy time recommendations that, and now they're assuming everybody's born at home, which is not true, but they say as soon as you get home from the hospital, you start tummy time. It's just, you know, short periods of time or, you know, on your chest in a certain way. But you definitely want to start it right away because it's the natural, normal biological position of being held. Okay. And every baby loves to be held, and tummy time is being held. And when they're this way, it's held by Mother Earth. And when it's this way, it's held by their mother. And if it's a position of being held, and all babies love it. Now, if we wait and they already have tongue dysfunction and autonomic dysfunction and all these different things, and we wait until they're 2 months old to try tummy time and for them to like it, there's going to be challenges and barriers to that if they have oral dysfunction. So we need to look at not liking certain things that are normal developmentally as warning signs that we need to look at function and dysfunction.
I guess my next question comes with that. Why do some babies hate that position? We hear hate's a strong word, but why do some babies really do not like tummy time?
Well, because it's challenging, because it's provocative of certain things that are very intense. They haven't had the experience. You know, we haven't read their cues. We didn't get them there the right way. We didn't prepare them. They haven't gotten that kind of information, and we all of a sudden threw it at them. They actually have a tongue dysfunction. They have airway patency issues. They have this big distended abdomen, and they're finally getting some movement going. And even though that's a good thing, it's intense. If you've ever had gas bubbles moving through, that can be quite intense. And things that are even good for a baby, and it's their first exposure, they can get upset. And we learned early on in the oral feeding world that we needed to offer a new food like 12 to 21 times before you could perceive it as not a threat. Okay. So we got to look at all these different angles and find out what is the exact barrier this baby. And that's another reason why I developed tummy time method, because the professionals who've trained in it can use a discerning eye and be able to help problem solve. And it individualizes it, even though it's sort of a standardized protocol thing. It individualizes it because we do want to find out, why does this baby having a challenge here? And it's going to be different for a lot of different babies. I'd love to do like a reality TV show where all I do is like come in and just problem solve tummy time problems. If you guys have a hookup for that, let me know.
I will.
But sometimes, like, here in my office, I'm just like, you know what? Let me manifest a baby that can show up, that can really challenge all my theories about how to get a baby. Because I've never had a problem getting a baby happy in tummy time, ever.
Is there a way the mom should be? How do I start as a mom? I just got home with a newborn, you know, because I was obviously totally on that boat that my kids didn't like it. And I did exactly what you said. I just threw them on it. Of course, they're going to hate it. Now I know. So how should I approach that? How should I start? Is, you know, a couple seconds enough? Should I be doing it at least a minute, at least 20 minutes? How should I just start?
You got to find just right.
That's a great question. Go ahead, Ruth.
I always say you have to just find that just right challenge.
Yeah, definitely. But, you know, in today's culture and, you know, the way we are, and because we are in, you know, a back to sleep culture, we actually need sometimes professional help. So just like you would hire a lactation consultant, you will hire somebody that's been trained in how to do it to teach you. So that's another thing, because it's affordable and you could teach to have someone tailor it to you. So that's like the newer thing, having professionals that can actually help you problem solve and individualize it for your baby. I've got that training program. But as a generic recommendation, we're always going to start it on our chest the first couple of weeks, because they need to live in the habitat of the parent's body for a large majority. But we can do a little bit of modifications. We can turn their head side to side. We can lay back a little bit more. We can work with doing some even massage or touch in these positions. But we can also then add a little bit as when maybe we lay them down for a diaper change and we just roll them over for one little 10-second tummy time and rub their back a little bit, maybe wipe their booty and roll them back over and pick them up. So having these really small experiences will give the baby a lot of variety and complexity, and it's not as challenging. And it's done in a way that isn't stressful, and it goes in with the daily care activities. And then as the baby gets older, if we start this young, they always like it. It's really the problem is when we wait, until a little bit later.
I love it. Thank you.
But I gotta be honest with you, if you think about it, lifting up your head in tummy time is directly going to be involved with your tongue position, lengthening, strengthening, and your jaw shape and size. So we know why a lot of these babies are having trouble.
Mm-hmm. Definitely, Diana.
But it's also the antidote.
It's also what?
It's also the antidote.
That is so true.
Ooh, Diana's got a great question about how does she help herself now for her future baby? Love this
so
question.
They don't struggle.
Okay.
Let's see.
Yeah. So one would be getting into an exercise and movement program that works for your body, and working with your nutrition so that you know what is unique to you. What is your nutritional panel? And I recommend getting a blood work done and working with a nutritionist. This is like a dream, okay? Then working with a pelvic floor therapist and a body worker to just work with massage and alignment and openness and removing, and really working too with maybe someone who has craniosacral background, because a lot of the craniosacral is actually emotional work for us bigger people. And we have emotional blockages in our bodies. And I know that, that played a big part in my own birth with my first baby, and that I wasn't emotionally prepared to allow myself to open up and allow this being to come into the world, that I was holding on very tight and tense. And despite pushing for 3 hours, we ended up with a C-section.
Wow.
I did VBAC the 2 girls, but it's the whole thing about how do you release, and there was just a lot of energy blocks. And that was when I'd gotten into cranial work, was around, my second baby. And so removed a lot of the blockages and the places in my body where flow wasn't happening. And of course, we still need to continue this work, on and on. But doing some cranial work, maybe some pelvic floor therapy, even some chiropractic, and going to someone who understands the impact of tethered oral tissues on the whole body and how it has an effect on the baby too. And then doing positive, visualizations and intentional, mindful, respectful time with yourself, envisioning a healthy baby. It's so important. And then when you get pregnant, making sure you get a doula and that you learn something like spinning babies or something about optimal fetal positioning. And again, seek the help of a professional. Thanks to our modern society, you can hire a doula who is specialized and can be your birth advocate and help you. And you can your partner you're just in this emotional thing. And then you have someone who's, professionally guiding you. We need these resources. It's just the village. Yes. It looks like a different thing, but it's the village.
And it is so accessible right now. You're absolutely right. In this day and age, it is easier, much easier to find people. Judith has a question. Can you treat torticollis without fixing the Tongkai?
You can improve movement. Yeah, you can make the movement system a lot better. Absolutely. You can optimize and have the baby working within their restricted range. Yes. You can also, though, help the muscles in the surrounding areas become more supple and able to lengthen more, which is like people like me who have a tie that have a lot of elasticity. And you can definitely make a lot of changes. Now, I wouldn't go so far as to say, then just forget about it, but continue to assess and assess and assess. And when you hit a wall, we do need to release tethered oral tissues because everyone deserves full range of motion of their tongue.
Voila. Michelle, I have a lot more questions, but we have reached our hour. This has been wonderful. We're going to have to schedule another one. This is so great. Ruth, do you have any last comments?
Thank you for sharing your wisdom. Always, I'm always looking forward to learning more from you. And so thanks for joining us today and sharing it with not just
Thank you.
So how can professionals get in touch with you? What kind of courses do you have going on right now? How can we learn more from you?
Don't get in touch with me. I'm just kidding. I'm just kidding. That's a good question.
You can let me know later, and I'll post on Airway Circle.
Yes. I mean, you can always go to the TummyTime Method website. That is a place where all of my courses are supposed to be listed. But honestly, I've really just been doing very exclusive groups for a little while online and really focusing on people who are just really passionate about learning the therapy aspect of it. And but we're coming back. I actually just made, oh, this is good. Just made and my first commitment, I'm going to take my Torticolos, the red pill course, to Las Vegas in March of 2022. Woo! So that's going to be good. Yeah, it is limited to therapists only, but that's probably hopefully a larger and larger percentage of your population of your following, because therapists need to be on the team. These are neurodevelopmental issues, and we have advancements and regressions and growth, and it's a lot of development things too. So we want these people on our team to round out everything else. It doesn't replace anybody. It's a complementary thing. So I've really appreciated your perspective on that too. You guys are awesome. Have a great day. Thank you so much.
Thank you. Have a wonderful night. Guys, we'll see you next week. Thank you. Bye-bye.
Thank you.